successful potentially coming to Porter. It sounds like an interesting scenario. Losing revenue from Act 55 has basically made more space under your revenue cap to allow you to provide more services. What other services do you think you would like to provide at Porter if you had space under your revenue cap to provide more services?
Yeah, so obviously any type of ambulatory access that we could provide, we would want to do. So I'd want to look at some additional specialties, whether or not we could, recruit additional dermatologists, which we used to have here in the community. Endocrinology would be great to have. Give me a wish list of specialists, and I'll give you a list. I think there's always efficiencies we can gain through our OR. That's where our pediatric dental cases would be done. So if that comes to fruition, if we're able to help the medical center decant some less acute services from the medical center to make room for the sicker patients there, we'll certainly do that. So I'd say the list is long, that we could, try and do that. And I see Ramsey came on camera here. He may have something to add here, but.
Yeah, I guess in the projected numbers, we already have some orthopedic volume, so we're expanding services there. We're looking to potentially expand some of our non-invasive cardiology testing down at Porter, which would be great. Porter's anesthesiologists will do pediatric patients, and so that opportunity for the pediatric dental was noted. And we've got an opportunity to expand some ENT coverage, some subspecialty coverage down there if OR space is available. But we're thinking broadly about what we can do for that community.
Great. Thanks, Randy. Let me just go through the rest of my things here. I'm trying to keep us moving fairly quickly. Okay, so there's some funny things. We talked about the top 5 high margin services and low margin services. I don't know if you guys take a look at that, but primary care is listed in both the high and the low. Just want to sort of point out that it looks like it was low in one year and then high in the next couple of years. Do you know what changed to move it from low to high margin?
I don't, but I know that I think the network's way of pulling the data was a little unique in that it attributed all services back to a discharge provider. But what might have changed in the data to cause that service to switch year over year, I can't explain that.
Okay. Since we're talking about kind of the attributing to provider, there's some of the RVU data is a little strange too. You have 1.3 APPs in your ED that earn an average of 10,500 RVUs per FTE. So I assume there's something going on with the RVU data. Can you give any explanation for what's going on in the RVU data?
Not at that level, I don't.
Dave, yeah. I'm sorry, member Merman.
Yeah.
Let me take a shot at that.
All right.
So in the ED there, they have single coverage MD with a single PA every day. The volumes are fairly high. And so the PAs are seeing a lot of patients independently. So they're doing their own primary billing. They're seeing a fair amount of patients, meaning a relatively high patients per hour. And importantly, they're also doing all the minor procedures. And so historically, the PA position that's at the Porter ED has fairly high WRVU data. That is purely the clinical perspective that would make that number make sense to me. Nothing more. I have not, dived down into that specific number.
it had there's some funny things in there where there's a few that are super high and a few that are super low that don't seem to make sense from a clinical standpoint. So I wonder if there's like a data issue there. I mean, for instance, the cardiology group is very high RVU generating, but is listed in the lowest 5 margin services. I would think that cardiology generates a reasonable margin if they're high RVU generating. So there's a lot of inconsistencies in the RVU data, and then looking at those compared to the margin data. So, okay. One other area of curiosity I had was that you're predicting pretty substantial increases in CT and MRI utilization, 15, 16%, and attributing that to the high ED utilization, but the ED utilization is only up by 4%. So just wondering if you could try to square that one as well.
Yeah, we've also expanded hours of operation, and that happened in the current year. So that's also contributing, eating to the backlog and reducing the wait times. So that's also boosting the current run rate.
Okay. And my last question was this budget reviewed and approved by the local board of Porter Medical Center?
It was reviewed with them, yes. And then it goes to the network board for approval.
Okay, so the local board doesn't approve it, they just review it.
Correct.
Okay. That's all I have for now. Thanks.
Good afternoon. A quick question. On the balance sheet that was provided to us, it shows $30 million due from related parties to Porter. And the fiscal year 24 audited financials showed 0. I was hoping you could describe for us what that $30 million relates to.
That $30 million relates to the due from Helen Porter. I'm not familiar with the audited statement you're referencing, which would have that at 0. We have not changed our accounting treatment of that. So I'd have to follow up with that discrepancy. But on the balance sheet that we submitted, I know that $30 million represents that due from.
Chair Foster, the 0 on the balance sheet, is that a network balance sheet that you're looking at there, or?
Yeah, it's a fiscal year 24. It's a September 2024 network audited financials has 0 due from to Porter Medical Center.
That goes back to the way that we need to treat our accounting being a consolidated entry that's an obligated group. All of those due froms when we produce our audited balance sheet, which the auditors require us to do, nets all the due tos and due froms against each other. So when you look at the network balance sheet, it's a 0.
Oh no, sorry, it's the consolidated balance sheet. It's page 67. It's a UVM Medical Center obligated group consolidating balance sheet, and it lists each of your hospitals and the network, and it shows the Porter owed $30 million.
Yeah, so if you're looking at the balance sheet that has columns for each of the individual hospitals, and then there's a column that has eliminations.
Yeah.
That elimination essentially nets all of those due froms down to 0.
No, I understand that. I'm asking where the money's going to, and I guess the answer was to Helen Porter.
It sounds like that. Yeah.
Okay. Is the entirety of the $30 million that's due to Porter from Helen Porter?
It is.
And again, same question. Why was it 0 in September 30, 2024?
That I would need to see the schedule you're referencing, because I'm not sure why it would be.
Okay. It's on your website. It's the audited fiscal year 24 financials. If you want to reference it, page 67. Okay. I had no other questions. Other board members?
This is Sarah. I have one question. On page 7 of your narrative, you talk about denials, and you say that due to your improved registration and prior authorization processes, denials in 25 are expected to be below budget. Can you talk about what you improved to get the denials down?
There are two things that, yeah, just want to make sure I was not on mute. There are two things that come to mind in particular. One is a focus on our pre-registration efforts, and so that we have the demographic and payer information for patients correct when they present for services. I know that's been a big push, and we've been able to pre-register more patients than we have historically. And then the other thing I would point to is an increased focus on prior authorization and prior authorization denials if we happen to get them, following up, getting the paperwork that we need. But that's been a concerted effort, and they've been, the efforts have been paying off. So those are the trends that we've started to see tip that we are hoping to continue.
That was my question. Thank you.
Any other board questions?
None for me, Chair Foster.
Healthcare advocate?
No questions from the healthcare advocate. Thank you.
Okay. It's 3:20. Why don't we take a 15-minute break and we'll come back for the network at 3:37. And I anticipate we'll go over time, but I don't anticipate going past 6:30. We'll try and keep it relatively close. Does that work for you all, or would you rather book a second day or part of the second day?
No, I think we'd rather finish it today.
Okay, let's do that. We'll try and keep it snappy. So we'll take 15 minutes and come back and we can take a recess. Thank you.
Let me just say, equipment and,
Mr. Miller, you back?
Yes, I'm back.
All right, we can go back on the record.
Okay, we're on.
Okay. All right, so we have some time to ask more questions about the health network and how this all interconnects through the network operations. A couple questions I had. First, does the health network track the use of shared services by each network member?
Rick?
So we track shared services in totality, but each member does contribute some cost to shared services. So we have two in our budgets. You'll see two different lines in there. You'll see a shared service credit line. And what that is that's the contribution that partner is making to the overall shared service costs. So just using an example, there are employed IT members at the UVM Medical Center that actually are, since IT is a shared service, are providing services to the entire network. The UVM Medical Center gets a credit for those IT costs that they're contributing to shared services. So you see that represented in that shared service credit line. And then their overall allocation of shared services based on total revenue you see come through on the shared service charge line.
And my question relates to the use of shared services.
Yeah, I think I know where you're going, Chair Porter, on Foster, on that. I think on any given day, on any given time, any given month, and I saw a little bit of it from what Anna was saying and Bob was saying and Steve was saying, is that certain organizations are going to need shared services more or less. I don't think we have that level of detail where we're tracking it. It's like a year to year kind of thing. So there may be when there's a union contract negotiation that is going on in a particular organization, there may be legal services that are committed and spending more time in that year with that organization. But I don't think we're allocating or accounting at that level. It's that larger piece of how we allocate costs. And then I think as Steve Leffler referred to, there's an ongoing, we think a healthy, honestly, dialogue around, hey, we think we need this service that comes from IT, and we're not getting enough of that. And we need more of it here. And other people may argue, well, we don't really care about that, but what we really need from IT is this. And so we try to bring those groups together in making determinations about what we're going to do in those shared service areas. And that's, of course, part of our challenge as we align and integrate to make these difficult decisions about different, I'll use IT here, different IT services that may exist at different organizations. And our goal is to say, yes, you may not be able to continue to get that, but we're going to give you this because across the board, this is going to bring us greater savings. And a couple of you will have to change, and a couple of you, will have to help us and teach the others why this particular IT service is better than the one that you're using. And we're going to save money overall across the whole system by doing that. So there's a lot of that goes on that doesn't necessarily, day by day get allocated that I can tell. And please, I'm going to transparently share where I see things, and I expect Rick and Ramsey and others to come in and correct me if I'm wrong. And I'll just put that out there transparently. But that's the way that I've seen it operating in the last couple of years. And as we're trying to integrate and align to be more unified, that's, I think, where we have opportunities, because I think we see systems that we can pull together more tightly and get shared savings as a result of that.
Okay, my question, is there any tracking of how much utilization of the shared services each network member hospital uses? It sounds like the answer is no.
No.
We have the shared services file that you submitted. Thank you for providing that. Are there any expenses associated with the health network entity aside from those reflected in the shared services document?
There shouldn't be. We've captured pretty much everything in that document. We even include other non-administrative costs. So we include depreciation, interest expense. There shouldn't be anything else that's network related that's not captured in that document.
Okay. And so this maybe is a colloquial way of saying it, but the health network budget is that $496.8 million. Is that accurate?
It is.
Okay. And in 2022, the health network total budget was $335 million. And I was wondering if you could explain the increase from 2022 to the 2026 budget from 335 to 496.
Yeah, so we can break that down. A part of that is when the question came up earlier about, you asked about transfers. So every year we do add additional, or we have been adding additional expenses to shared services. So part of that increase is transfers into shared services. I can even, if you're interested, we have a slide, not knowing exactly where we were going to go with the health network portion of this discussion. So just as an example, in fiscal year 26, so from the 25 budget to the 26 budget, we added $7.5 million worth of shared service costs that were transfers from hospital budgets into shared services because that $7.5 million needed to be allocated to the entire network.
How much of the increase from 335 million in 2022 to the 496.8 million in 2026 is due to transfers?
We'll have to get you that detail, Chair Foster.
And are there still services that overlap with the shared services at network hospitals? So for example, you mentioned IT. Does MC still have IT and then you have IT at the network as well?
The major shared services, so IT, HR, revenue cycle, those are pretty much all at the network. There are some smaller facilities related costs, employee health, and some other administrative costs that we do still have a little bit of that at the partner hospitals. It hasn't been completely consolidated at the network.
Okay. So what I'm trying to see is the apples to apples entirety of the network and member hospitals FTEs and expenses relating to these shared services. Can you provide that? We don't have that yet, do we?
I don't know exactly what Matt does have, but we can provide multiple crosswalks for you, Chair Foster, to even over the course of 3-4 years, whatever you would like to see, so that you can see exactly what has been true growth and what has been transfers into shared services.
Yeah, that would be great. That's exactly what we're looking for, is the true growth. And I think what we have is from 2022 to 2026. So that would be the time period I think most relevant. Do you know the compound annual growth rate of the network operations, setting aside the transfers?
Again, we'll have to get, I mean, looking at the total number with those transfers in there. I can show you actually one of the, are you okay if I put up a slide real quick, or would you prefer not?
Yeah, no, please. That'd be great.
So this is just to highlight the impact to shared services that actually were part of one of my opening remarks and one of the stats I quoted. So looking at shared services back in 2022, so administrative shared services back in 2022, when you apply just the inflation factor to that 22 number, we'd be at $419 million for administrative shared services in the 26 budget, and our actual budget is 396. So there's that compounding when you take out the transfers. I suspect, again, we'll get you the detail, but I suspect we'll see very little growth from that time period.
Dr. Merman?
Yeah, was that just for the Vermont hospitals? Or is that the whole network?
No, that was the whole network, but just to clarify, because I know there's, we spent some time with Matt and the team this week. There's two components to shared services. So there's administrative shared services, which that number is a number that we can benchmark against, because it includes all of those core shared services. It includes IT, HR, revenue cycle, communications, network operations, that sort of thing. That's the largest piece of what you see in shared services. But then there's another piece of shared services that includes any of the interest expense on the debt that the health network owns, so the debt that isn't specific to any particular partner. It includes depreciation for assets that the network owns. It includes the costs for the share of the department chairs. So both components make up the total shared service number that you see on the budgets for the hospitals when you're looking at that budget line in the budgets that you've been reviewing the last month or so.
Okay. And I want to get a little bit more of an understanding of some of the actual shared services and what they are. Finance administration. Can you describe what finance administration does?
So that area has accounting, payroll, analysis, accounts payable, and a few other finance related areas. It also includes, we include in that category, we've got two contracts where we were paying a contingency fee for some work in terms of our Medicare status, GME revenues. So there is, in addition to just traditional shared services or those finance related shared services, there are a few other related expenses that we put into that finance admin category.
Is that reflected when I say the shared services document, I give you the the title of the document is the UVM Network Shared Services Excel file. And for finance and admin, it's 34 million in 25 and 34.7 in 26. Is that contingency fee reflected in that file?
Actually, I don't mean to be trouble here, but is there any way that we can pull that up? I just want to make sure we're looking at that I can see the number.
No trouble at all. Kristen or Abby, could you pull that up? It's on our website. It's UVM Network Shared Services.
Yes, give me a second.
Okay. Mr. Vincent, while Kristen's pulling that up, who is the contingency fee paid to?
I believe it is, actually, well, I'll have to get back to Chair Foster. I thought I knew who it was, but I'm not 100% sure.
Is that some sort of contractor that assisted with the Medicare status and the GME submissions?
Correct.
What percentage of the additional payment that UVM received was paid out to the consulting firm?
We can get you that detail as well. We'll give you the name and the percentage that we paid for that.
Okay. And then on finance administration, the FTEs went up 9 year over year. Were any of those transfers from network hospitals?
I suspect they were, but we can get you a firm answer on that.
Okay. And then health network DEI, I assume, is diversity, equity, inclusion. Could you describe what that group does?
Sonny, I don't know if you want to take that one.
Sure. So they're also a network service across the system, and they have, I would say, 3 really big goals in what they're trying to do. One is in the way we deliver care and trying to ensure that we deliver it equitably and that we know that we have concerns around the way we deliver care, as all systems do, around if we're doing it equitably or not. We also know that if you're in a poor zip code in any of our health system service areas, that you're going to have a lower mammogram rate, a lower colonoscopy rate, your hemoglobin A1C, if you have diabetes, will be higher. And so one big function is, what are the things that we can do system-wide to ensure health equity is continuing to improve? Two is in the way that we collect information to ensure, in that same piece, to ensure that we're actually capturing both real data, that is race, ethnicity, and language data, as well as SOGI data, sexual orientation and gender identity data, because we know that those groups do not do as well overall in health equity. Internally, inside of the organization, that group is also responsible for ensuring that our hiring practices are equitable in every way, and that we don't bring in preconceived biases and notions when we're hiring, and the way we treat our employees, and the way that we look at our employment engagement surveys, and making sure that we all those underrepresented groups feel like they're fairly represented, and that they have a voice here, and that they feel included in the work that we're doing here. And so I think if we look at that, that's probably the largest part of the work that they're doing to ensure that because part of what I always say, and I think what we try to do, is that we're delivering high quality, equitable care, accessible care, affordable care to our communities. And so that's the portion that they're playing.
Do you have a mechanism to track the improvement in delivering care equitably?
We do. So we have year to year, at least since I've been here, looking at specific factors and how we do in that space. So some of those things I mentioned are part of that. So it's the challenge that we have is that number one, so yes, the answer is yes, we do. And so we're trying to look at those factors and seeing if we can drive improvement in that space, driven largely by zip codes, but we're doing that work right now.
Great. If you don't mind, I'm curious to see it. It could be a really interesting model for other hospitals. If you could send me the factors that you look at in evaluating the improvements in that, I think it would be beneficial.
Sure.
External relations, what is that and what do they do?
So external relations are the factor of communicating outside of our organization, and the messages that we sent out. It could be anything from the way that our website puts out information for our patients to be able to understand what services are where. It could be the way that we communicate changes or information. It could be the way that it is the way that all these things, I shouldn't say it could, it is the way that we interact with the media for media related issues. It's the way that we interact with our government officials, and external could also include any lobbying services that we employ. There's probably more in there, but off the top of my head, I think those are some of the factors there.
And in that bucket, in this budget, it's going up 6 FTEs. Can you explain why that's increasing by 6 FTEs?
I would have to get back to you. I'm going to go back to it that the most likely reason is that we've transferred from what was sitting in a hospital budget into the network. I'll get back to you on the detail on that.
Okay. And are there any additional expenditures on outside third parties relating to this external relations bucket, such as consultants, contractors, lobbyists, marketers?
Sure, I'm sure that they are. For example, we outsourced a number of employees for our website and website management. So whenever we don't have the internal resource to do it and we need it short term, we use external forces. So I'm sure that there's a number of them. We can supply a list and the dollars associated with them.
That'd be great. Yeah. Do you know how much the external spend is in external relations?
I'm not sure what you mean by external spend. The dollars that leave the system?
No, spending on outside contractors, consultants, lobbyists, marketers.
No, I don't know what portion of that expense actually goes out to consultants or external folks. We'll give you that same level of detail.
I mean, this is-
Unless Rick, do you know those numbers already or?
No, we'll
We'll
provide that detail.
Mr. Vincent, is the number that is reflected on the shared services document, does that include the external spend or is that just the internal expenses?
No, that would include the external spend as well.
Okay. Kristen, do you have that document available by chance? Oh, you do. Okay. Yeah, so let's go. Okay, external relations. So the total expense is 9.1 million for 2026 budget. And then you've got $5.4 million in management and all other salaries, leaving about a little under $4 million. So is that, what's the remainder of that 4 million go to?
So that again, that must be the external spend, but we'll get you that detail.
Okay. And then Kristen, if you can just scroll up to the finance and financial administration. Sorry, I didn't get it. What is it called again? Yeah, finance administration, line 14. Yep. And so, Mr. Vincent, my question here, you wanted to see the document, whether or not that contingency fee is reflected in this document. Does this help refresh your memory? And if not, you can get back to me.
It does, yeah. The total expense line on all these is all expenses. So it looks like it was a breakdown of providing. So of the 34 million, for example, in the last year's budget, 20 million of that is personnel related expenses, with the rest being non-personnel, which contingency fee would be in there. Any systems that we're paying for, outside consulting, those types of things would all be the difference between the total expense and the salary numbers that you're seeing for each one of the shared services.
Okay, thank you. And then I wrote this number down, it may be off, but I thought during the UVMMC presentation, there was reference to several thousand people waiting for colonoscopy. Does that sound correct?
Not ringing a bell for me.
I don't remember that.
I'm on. That's correct, Chair Foster.
Okay.
About
yeah,
3,000.
Okay, yeah, okay. I was wondering what steps the network is doing to move those patients waiting for a colonoscopy to another site of care.
My understanding, Chair Foster, is that people call in for the colonoscopies. They're offered multiple sites to get them. They can choose to stay close to home, which might take longer, or choose a different site. I know Brad and Ramsey are still on, but my understanding is when you call now, you're offered more than one location.
Okay. More than one UVM location or just another UVM location?
I believe because we're scheduling them, it's UVM locations, network locations. We're not scheduling for the private providers doing that.
Yeah, not scheduling, but providing the option or recommending people to go somewhere outside of the network. Does that happen?
I know that at times our primary care providers will refer people outside the network if there's someone needs something timely that for some reason the network can't deliver. I don't believe the schedulers are doing that, but I know our primary care docs do that at times.
I think there are certain services, and Ramsey's going to come out. I think there's certain services, Chair Foster, that people know. I mean, I think aesthetic dermatology is an example where I think the norm is to refer outside because they know what our capacity is. The only other thing I'd mention, and Steve, you can comment and maybe Ramsey on this, is that we know that we have this issue with colonoscopies, that it's difficult to find places to schedule them. We've actually taken a move to do the FIT tests as well, so that for patients that qualify, that we will use alternative testing that we do have accessible and it's lower cost to do it. So I know that we've made a concerted effort understanding that this is an issue all across the state. So that's another piece that's really important to just, we're looking for alternatives. We're looking to try to do the things that we can for our patients. Even the scheduling piece is a relatively new thing to be able to use the technology that we have to open up and see what's available and where. But you're right, inside of our, you heard it, I think at both CVMC and Porter, that we are challenged with gastroenterologists, and then challenged with just, our goal is continue to maintain access in that space. Ramsey, were you going to add something?
I was just going to add that the backlog, of course, has been challenged by us not having enough employed gastroenterologists to hit that backlog. And the strategy, I really think, as we look forward, is to optimize the number of people that are getting non-invasive testing there and screening off of the FIT test. But you hit that already, Sunny.
Well, so, UVM is very expensive on colonoscopies. 3,000 people backed up is a lot. That's people who, let's hope none of them have cancer, but it seems like it's an opportunity to move them to other sites of care outside of UVM Health Network. We are trying to drive down and move out care from hospitals to lower sites. So I would put that in, just a flag that this is a goal for the state. We don't want 3,000 people waiting, and we don't want them paying UVM's prices. So perhaps we can use some of the advertising dollars or some of the PHSO work to move some of those patients. I know many people are able to get in pretty quickly at Green Mountain Surgery Center and other facilities. And overall, for affordability and sustainability of our system, that's something that I think we should be evaluating, not just keeping it within the network. And it probably applies to many other tests and screenings as well. So I want to flag that as an opportunity to drive down costs and revenue. UVM HN administration, I think I know what this is. It's line, Chris, let me get it for you. Sorry, Health Network Administration, line 157. And Chris, I think if you make C and D a little bigger, you can see the numbers. Could you describe for us what that is?
So that's all the senior team here at the network. It also includes, again, you can see on all of these, there's going to be a difference between the total cost and the FTEs or salaries. So this cost center also includes charitable contributions that we make, includes corporate memberships. For example, it includes the contribution that we're making to AHEC to help with recruitment and retention of physicians in Vermont. And I believe it also includes if I'm not mistaken, I think it also includes the academic support payments is the other big difference between the 27 million and the salaries that you see there.
It looks like from fiscal year 25 to 26, there's been no reduction in health network administration or external relations, and I was curious why.
I think we have to go back, certainly for external relations, and look at the transfers from our organization and the movement there. I know, for example, philanthropy moved into external relations last year. That might have been a chunk of employees. From our health network administration, again, I think we'd have to go back and give you the detail on each individual. I don't know if you have that accessible, Rick, but.
No, we can. I think the detail will provide some light on what's been a transfer and what's been increasing. Chair Foster.
Okay. And philanthropy, is that on this recorded as health network development?
It is, yep.
So a separate bucket from external relations reflected on this sheet?
Correct.
Sorry, my mistake.
No, that's okay. I just want to make sure I've got the right terms so I follow. Expense reductions. There's been some press, and I spoke with a couple of you, I think maybe before the press was announced, about some of the expense reductions. And in fiscal year 25, there was expense reductions taken too in response to the board orders, closing Mad River, transferring transplant to Dartmouth. And I want to know the total amount of expense reduction associated with the fiscal year 25 budget.
In terms of administrative and clinical reductions.
Yes, please.
So we'll get back to you on both of those numbers. They've been a component of all the presentations today, but we'll itemize that for we'll put it all together in a summary for you.
Okay. Do you know directionally how much expense reduction occurred in fiscal year 25?
On 25, I apologize. I thought you were talking about 26. So no, we'll have to get back to you on exactly where that's at year to date.
Okay. And then fiscal year 26, I see in the submission for UVMMC, it's page 4, 19 million travelers, 9.5 purchase services, etc. And can you give me the total expense reduction across the network for fiscal year 26?
We'll get back to you on that, Chair Foster.
And I understand there's 146 positions, 77 existing, I think 69 open. And I was trying to find where I would find these positions being removed. Would that be on shared services or where would I find them?
The majority would be on shared services, and we can create a crosswalk to show you where you see that in the budgets.
Okay. And you don't need to give me the exact number for purposes of discussion, but approximately what is the total dollar value of the expense reductions in the UVMMC fiscal year 26 budget?
So it would be pretty much those items that were flagged on that slide. Actually, I think you were just quoting the numbers there, Chair Foster. The clinical cost reductions, administrative cost reductions in the travelers would be, I believe, the total, but Judy, I think, is still on if she wants to augment that at all.
It looks about.
Apologies, I was on mute.
Go ahead, Ms. Peakley.
Yes, I'm just going back to that slide component for our expense reduction that we had put in. So apologies.
It's also at 4 and 5. 4 and 5 of the narrative as well.
Okay. And I apologize. I just tend not to quote numbers off of the top of my head. There's a lot of them.
Good habit for a CFO.
Thank you. Right. So you can see the areas in our expense reduction are primarily focused on our traveler expense, which when you net it down was the about the 8.5 that I mentioned, because we are replacing travelers, not a one-for-one basis, but replacing travelers with our employed staff, primarily in nursing. Purchase services reduction, I'd have to get the detail of that for you. The expense reductions that are flowing through, remembering that the health network does flow through the entity for UVMC. So there's the 4.5 related directly to software IT. And then when we look at budget to budget administrative type expenses from areas that in our rev cycle and other areas that we have been targeting for efficiency is budget to budget down 23.9. The focus area for the largest area of expense savings is nearly 30 million in what we've put together for efficiencies within our care for our patients. We're looking at not reducing care. We're looking at how do we make it more efficient? How do we ensure that at the end of the day, when the patient receives the bill, that everything is appropriate? We have ensured that the care that we delivered was what was necessary, as well as what was in the best interest of the patient in terms of affordability. And are there any opportunities that we have there for reducing cost of care? So I don't know if that covered everything, but that is kind of the intent around our cost savings and,
think so.
focusing on the affordability component.
Yeah, okay, so that's about how I understood it. So that totals right around $90 million, give or take a little bit. My question is, when I look at the chart on page 4 with your fiscal year 25 budget, the total expenses at UVMMC are 2.254 million, and the fiscal year 26 budget is 2.347 million.
Yes.
And so that's about 90 million, yeah, around 90 million-ish more. So what are these savings coming out of if they're not coming out of the total expenses?
Well, you can see that they are primarily, when we look at budget to budget increases based upon inflationary rates and also in our salaries area, all of those are subject to inflation and cost increases. So we're pulling those down in our non-salary. That has been our focus for non-salary expense reductions. So when we look at where we projecting for FY25, you can see that our projection based upon the patient care that we've delivered is running, you can see that $1.055 billion, and we're reducing that to $1.009 billion, almost $1.010 billion. So it's that line that you're primarily seeing that reduction in.
Okay, total non-salary expenses went from $1.5 billion to $1.9 billion from 25 budget to 26 budget.
Correct, budget to budget.
Okay, so that's up. These are all up, is what I'm saying. And you're saying that there's expense reduction, but these are higher.
Yes, sir. You are budget to budget. You are exactly correct. The actuals that we are experiencing are exceeding our FY25 budget. Some of those we've actually walked through in our mid-year. Part of it is related to higher than anticipated expenses. Part of it is related to the additional care that was delivered. So we've tried in our bridges documents to break out anything that's generating revenue. And then we're looking at how can we, when we're looking at delivery of services, how can we make the delivery of services without significant reductions move from that $1.055 billion down to that just right over $1 billion.
I think the key missing piece, Chair Foster, is the growth in terms of volumes, any new drugs, those types of things that when we talk about expense savings, the way that I would look at it is the cost would be that much more, that would be that much higher. So, pick the $90 million figure. Had we not done that, because we do have increases due to volume and other related expense drivers that are all tied to doing more than we did in the prior year.
All right, so I'm coming at this from the perspective of the people paying the tab, and the people paying the tab are not saving $90 million over last year. They're paying $90 million more than last year. And what you're saying is, from your perspective, it should have been even more than 90 million. It should have been 180, but you reduced it by 90. So Vermonters are only experiencing 90 million more. Is that a fair summation?
What I would like to add to that is a perspective. How I look at it is what Mr. Vincent mentioned. It's related to care delivery. And what we're looking at is how do we deliver that care at a lower rate? So when we made our budget for FY25, we've gone into a mid-year and shown where our revenue has come in higher. But there are also, those expenses are also in that FY25 projection column. So they're both tied together. So it is correct that we are exhibiting additional revenue and the offsetting expenses, and we're working to reduce both of those because that's the affordability factor. And there is a budget, and then there's the reality of delivering the care. And so what our FY26 budget does is try to take into account what care needs to be delivered and how can we do it less expensively? Because when we look at what we're actually experiencing, what our patients are actually demanding of us, that does exceed that 25 budget number that is in that chart on page 4. And that is exhibited by that middle column. So it's a matter of trying to take what the reality is and make it more affordable.
Do you have any sort of spreadsheet that walks us through what, I would think of subtracting it from the budget, and you're thinking of subtracting it from some other number. Do you have a spreadsheet that shows us that other number from which you're subtracting these savings?
Certainly, that is with our projection that we provided, and we can certainly add to that if there are other components that need to be explained. So we're required to submit our FY25 projection for revenue and expense and how that looks different from our budget. And we do attempt to provide explanations for that variance in terms of what our projection is looking like. And that is where you would see the increase in our volume, increase in the expenses related to care delivery. We've mentioned every single month in our reporting out to Green Mountain Care Board staff about the high cost of drugs, and that is certainly in our non-salary expense. So the reality of FY25 budget to FY25 projection, the difference in that is the reality of caring for the patients in FY25. So recognize it is an increased budget to budget, but I will say that we are working extremely hard to bring it very close to our FY25. And percentage-wise, I think that you would see nominal increase given the level of care that we are delivering. So I will say that we are committed to meeting the affordability. There will be a runway and a path that we have to get there versus, a cliff for us to fall off. But we are, and I think it shows in our numbers that we are committed to that. But I'm happy to provide anything additional. Didn't mean to cut you off there.
No, I appreciate that. Just seeing I want to see what the math is that you're projecting the subtraction from. That's what would
Absolutely
be helpful. Okay.
Absolutely.
And I understand your point about a glide path and a cliff, and that's something we try to understand and evaluate while recognizing that Vermonters feel like they're being driven off a cliff if they haven't already, particularly with some potential other changes coming. I want to talk briefly about contract negotiations. Is Ms. Champney still on? She might be the right witness on these.
Yes, I'm here.
All right. Actually, so the first question I had was the liaison to UVM, the team submitted a recommendation to DFR and the Care Board last week that we should cap all prices at 500% of Medicare. And I was curious if UVM has a sense of the revenue impact that cap would have.
We don't. We saw the same letter when it was posted online and discussed with the liaison. We don't have an assessment yet, Chair Foster. We are in process of evaluating. As you know, it's complex of what percent of Medicare to not go down the rabbit hole. So it would be significant. We do have some that are under 500%. And then obviously, as you know, we have some that are higher and at times greatly higher. So we don't have that number yet, but I do know it would be significant.
Okay. Yeah, and the high margin services, that document was a little bit different than I think some other hospitals had submitted it. Can you, and maybe Member Holmes already asked this, but can you provide us a list of services that are above 500% of Medicare and the corresponding revenue from those services?
We can follow up. I might have some follow-up questions either for you or your staff to get to the right level.
Yeah.
So if that's okay, there might be a conversation just to make sure we're providing you with what you're looking for.
Yeah, of course. One of the other things that we've heard about is this negotiating dynamic that sounds difficult. And I think in the liaison's letter, they wrote that UVM has advised Blue Cross that if you don't give us this budget or this rate allocation, we won't see Blue Cross patients. Is that allegation accurate?
Those words have never come out of my mouth or my team's mouth, so I would not categorize that in that manner.
Has UVM in any sense ever threatened to not be part of Blue Cross's network?
Predating me on potential terms, I know we have gotten to very tough conversations before. To my knowledge, there's not been a termination conversation.
And no threat of a termination or discussion of it?
Not that I'm aware of.
Would there be somebody else who would be aware of that, or would you be the right person if anything like that had ever actually happened?
It depends on how far back you would go. I've been in this role for 4 years, so I can tell you that. Before that, I would defer to Rick or others.
Mr. Vincent, do you have any knowledge of UVM or the network ever threatening to not have Blue Cross in its network if it didn't accede to UVM's contract demands?
Not that I can remember, Chair Foster, but again, that's tapping the memory bank a little bit. No.
Has UVM ever agreed to a lower rate increase than Blue Cross? I'm sorry, than the board, the Green Mountain Care Board approved with Blue Cross? Sorry, let me strike that as a terrible question. Every year the board issues a rate cap increase. Has UVM ever negotiated and agreed to a rate cap increase with Blue Cross below the board ordered cap?
So I'm going to give a high level. If we want further detail, I would ask for executive session just to the contract terms. And I think I've testified to this as of last year, as we submit our budget, it's based on revenue assumptions of utilization, payer mix, and collection rate of the rate we need. How we apply that rate at each payer is different because their starting point is different. So an MVP is different than Blue Cross on how they pay certain terms. We also take into consideration, how we're working with payers, whether it be on a value-based program or the administrative burden. So high level, we contract in, if there's a -1 for last year, for example, we apply that -1 across our payers. There are definitely nuances on how that gets applied and how we work with the payers to understand their areas of focus.
My understanding is historically the network and Blue Cross and insurers, and again, Ms. Champ, you're correct. If we get too granular into contract negotiations, we can do executive session. I'll try and keep it high level. My understanding is the negotiation will yield rate increases on some services that are extremely high, well above the care board cap, and some will be below. Is that accurate?
I'm going to restate what I believe is accurate. So I would not say that's accurate, and I'll give last year as an example.
Do the years before, because I understand last year is a little bit different.
Years before, we would increase some that may be above, if you approved a 3%, so I'm going to use an arbitrary number. If you approved a 3%, there may have been services, and there were services at Blue Cross or a Cigna or MVP that may have been higher because of either comparison to where we are with other payers, if they come, or excuse me, other providers, that they come to us and ask for a lower rate. There may be a lower one. So in aggregate, we would get to that 3%. And yes, you're correct. Some might have had a 6% increase. And we do that modeling with each payer to make sure it comes in aggregate, also starting off with the same base point. So we know what we're modeling with our payers.
And I may have asked this last year, but do you model or audit during the year to make sure your modeling was accurate?
So we look at collection rate, I'll say at a high level, as I know the CFO partners do, of what we're expecting. And that takes into a couple of terms we're actually getting from payers, where they do put in payer policies that are not expected at budget. We are working, and we had this in conversation with Blue Cross, so I can say this at a high level. We're working with Blue Cross to get to that audit or reconciliation. Chair Foster is another term. Not all payers require or want that, and they'll check the modeling. With our unit costs, we feel very comfortable that we've agreed with our payers. There has not been a formal audit. If a payer comes with a concern, they have that right. They have at times. And if we identify an issue, we go to payers. So it's, as it should be, in my opinion, a collaborative process of bringing up issues as we find them. There hasn't been an aggregate reconciliation to this date.
Okay. And one of the other issues we're trying to understand is the concept of revenue neutral, where an insurer may say, hey, you billed us wrong for this or this. And my understanding is at times UVM would respond and say, that's fine, but if we're going to make a change, it needs to be revenue neutral, as in you need to make up for that removal of payment in some other area. Can you describe your awareness of that?
So at times that does happen as we create our budget. We don't know of payer policies. We are working with our payers to get out ahead, saying if you're going to change a policy, I would not categorize us as winning those budget neutral. So they will have a negative. For example, ED downcoding has been discussed, I believe, or at least you've heard it in the news. Many payers, not just Blue Cross, have implemented those policies, and we have not been successful. In the most part, we will go back with payers to say this is why we have appropriate coding. You saw in the legislation the cotivity edits by Blue Cross, and which led to Act 111 last session, 2 sessions ago. We did not win that, and we worked through legislation to limit it. So it is a handful at times, I'll say, in a positive way, and a positive collaboration, specifically with Blue Cross. There was an HIV test that was being limited due to their payer policy. We raised the issue from our clinical team and our revenue team, and they actually added it to the policy to say it would be covered because it was an unintended consequence of an edit. So we do have those conversations, sometimes to ensure we're getting paid for the important test. Other times it creates a significant hole in our budget that was not captured.
When you say hole in your budget, the care board's budget approval is a cap. So if there's a hole in the budget due to appropriate utilization management, why would UVM recover that?
So I'll go back to how our budget is developed. We have our commercial rate based on what we feel we need to meet our budget expectations. If there's policies, for example, and changes on how implants are paid, which that came out a couple of years ago on a number of our payers, that is a very large impact, especially at the medical center. We're doing a lot of implants. So that is expected from budget, so from our budget terms. So I believe it goes to the different view of how we're making up our commercial rate is not expected as a cap. I sometimes think of that, it's the sticker of what we actually need to meet the revenue. It's not a negotiation standpoint of I'm going to start higher, you're going to start lower, and we come to the middle. It's what the rate is, and that's what we're filing with you.
And Ms. Chapman, this may be for you or maybe for others. Have there been any discussions at all regarding moving infusions from Vermont to New York to avoid the cap? And I know we asked Dr. Leffler this, but since others are on, I wanted to ask it again.
I think Dr. Leffler answered it correctly, Sunny.
Yeah, I'm just going to say the same thing. Our goal is to keep care close to where the patients are. And so that hasn't changed. And if there's an opportunity that we identified a year ago, 2 years ago, where we're seeing a large number of a particular kind of patient, GYN onc patient coming from New York, we say, can we provide that service? Is there enough volume that we ought to provide that service closer? And it could be CVPH or it could be Middlebury at Porter. So that hasn't changed. And so I don't think there's anything else that is there. Typically, what we've seen is patients come to Vermont because come to Burlington because that's where the services have been. And I think that will probably continue, but our goal remains the same. How do we deliver care close to where the patients live?
Yeah, I think providing the care in the place closest to the patient that makes the most sense is entirely logical. Moving patients to avoid a cap would be something different entirely. But thank you for that answer, and I appreciate you guys responding to that. I wanted to move a little bit to days cash on hand, and these are probably for Mr. Vincent. What is the floor for days cash on hand for the network to not violate the bond covenants?
So up until a month ago, it was 90 days cash on hand. We've since updated our MTI just to give us a little bit more cushion, knowing all the potential unknowns that we have with, as we shared in our opening remarks, and I think the board is aware of as well, potential cuts coming to Medicaid, premium tax credits, all the unknowns that we have as we look into the future. We did get 50% of our debt holders to approve a new master trust indenture, which brings that now down to 75 days.
And currently, the health network days cash on hand is 131.
Correct.
And what is UVMMC's days cash on hand currently?
I think that was on a slide that Judy had. Judy, I don't know if you can take a look at.
Yes, we were projecting based upon the budget that we submitted for our days cash on hand to move to approximately 134 days. However, I will reiterate that that was prior to the final rule for Medicare, which does bring down our days, at least by a day, 1.25 days based upon the change in the final rule.
Okay, and that's for 26 budget.
Correct.
Okay.
And we're running about 130. We run anywhere from 128 to 131, 132, depending upon activities in the market, how non-cash things are flowing through. So that's about where we've been running.
Got it. Okay. And then in the appendix that was submitted, page 40 in the submission, it's the balance sheet. And it displays the UVMMC, CVMC, and Porter balance sheets, but it does not provide a balance sheet for UVM Health Network. Are there additional assets such as cash? I ask it each way. Is there additional cash and cash equivalents at the health network beyond what's displayed on page 40 of the appendix?
There are, and we did have some correspondence with your staff on the fact that we don't generate a health network balance sheet. We have a health network financial framework, which sets the targets for days cash on hand, debt, margin, all of our key metrics. But to answer your question, yes, we do have other assets besides what you see there on that balance sheet for those three organizations.
Okay, and what you're showing us in this balance sheet you provided, that's current as of when?
I'll have to defer to Judy or maybe to Mark on exactly what time period that. Actually, if one of your staff has that, perhaps they can pull it up. The time period might actually be listed on that schedule.
I didn't see it myself. All right, I think I get the sense. So your audited financials from September 30th, 2024 have UVM Medical Center at 234 cash. This has it at 238. So, and the other numbers are relatively aligned as well, give or take 10 million here and there. And the cash at the health network as of September 30th, 2024 was $68 million. The short-term investments was $107 million, and board designated assets was 115. I'd just ask that you provide an updated set of numbers consistent with what you provided in page 40 of the appendix. And in terms of the assets at the health network, cash, short-term investments, and board designated assets, where did those come from?
So a big piece of it came from some debt that we incurred. I'll have to go back and see exactly. We borrowed about $50 million, 4 or 5 years ago. Might actually go back further than that to capitalize the health network. In addition, we've been generating obviously some investment income and some other revenues, but the bulk of that asset base goes back. We can get you the exact date on when we borrowed money to capitalize the health network.
It's close to $300 million. Was there any cash provided from any of the hospitals up to the network?
So there is, as we're paying for shared services, there are transfers that are happening between the hospitals and the network as well that we can break that down in terms of how that's accumulated over time.
Okay, and which entity incurred the debt that you referenced?
So that was incurred by the health network.
Right. Yeah, if you could give us a breakdown of all the contributions by the various hospitals, including New York, that went into the unrestricted assets at the health network, that would be helpful. And how do you allocate those network assets to member hospitals?
So it depends on which asset you're talking about. So investments, for example, are all managed centrally at the network level. They're in one account for investment purposes, but we do keep track of how much each partner's balance of that overall investment portfolio. In terms of cash, we have each partner still has a cash balance, has cash accounts. Most partners have short-term investment accounts as well. So we're managing all cash and investments centrally, but we're still keeping track of exactly where it came from, who holds what. As I said, many networks at this point don't have that level of breakdown anymore. The cash is all consolidated into one account, and all the bills are paid from one account. But we haven't made that change yet.
Are you contemplating making that change?
So it's something that we're considering, but given because there's a significant amount of efficiency that can be gained by making this change, but we wouldn't make that without discussion with the board, because obviously the accounting and just where those assets sit, we want to make sure that it was very clear what we were doing before we made any of those changes.
Okay. If you could give us a breakdown as well of the balances for each of the hospitals relative to those assets, cash, short-term investments, and board designated assets, that would be helpful as well. In terms of those network assets, how are those reflected in your calculations of member hospital days cash on hand?
So the only things that can count in days cash on hand are cash, short-term investments, and then unrestricted long-term investments. So any restricted funds that have been donated to the hospital or the network don't count towards days cash on hand. So it's cash, short-term investments, long-term, unrestricted long-term investments divided by the average daily expense to run that particular hospital. And then we have an overall number for the health network, which is 9.4 million. So when you combine cash, short-term, and unrestricted board designated funds and divide that by 9.4 million, that's how you get to the 131 days cash on hand that we're showing on our financial statements.
Right. And when you do that calculation for days cash on hand for the medical center, you include both the medical center's unrestricted assets and its portion of the health network unrestricted assets?
It includes, anything that's attributed to the health network and UVM Medical Center. Yes, that's correct.
Right, okay, so I'm gonna make up a couple numbers, I don't have them, but the cash and cash equivalents at UVM Medical Center's $234 million as of 24. The health network has another $68 million cash. Let's say that medical center has, 50% is attributed to of the network asset cash to the medical center. So you take the 234 plus 34, and all of that would go into that calculation for the medical center's days cash on hand.
No, so the medical center's calculation would just be based on the medical center's accounts, not the health network numbers that you were quoting there.
Okay. But you said the medical center actually has accounts for cash, short-term investments. The medical center's portion of those network assets is not included in the medical center's days cash on hand methodology?
It is for investments, and we can get you a crosswalk because some investments actually are held at the network level as well. So we can give you a breakdown of the portion of the unrestricted board designated funds that are part of the UVM Medical Center's days cash on hand.
Okay. So looking at the balance sheet from 2024, 68 million cash, 107 short term, 115 million board designated at the network. What you're saying is some portion of that amount of money is being included in the calculation of UVM's medical center's days cash on hand.
Correct.
Okay. And you'll give us a breakdown of how much of those assets are being included?
Yes.
Then the New York hospitals, we had some confidential data relating to prior years' financial performance, operating margin, days cash on hand. And I think you suggested earlier that they're closer to break even and Alice Hyde is positive. What is the days cash on hand for the New York hospitals currently?
Yeah, we can get that to you, Chair Foster. We'll give you for each hospital, and if you want a combined number, we can provide that as well.
Okay. Yes, please. I did some very rough back in the napkin calculations on the day's operating expenses for the New York hospitals based on the 2023 Form 990s. So it's a little bit dated. But it was about $453 million was the expense for CVPH, 105 for Alice Hyde, 60 million for Elizabethtown. And so if I want to come up with the days cash on hand calculation that's needed to hit 130 days cash on hand or 175 days cash on hand, I would divide that total amount of money by the number of days in a year. Is that correct?
Yes.
Okay, and then, all right, so my rough calculation came to $1.7 million. And then to calculate what 130 days would be, which is about the networks, it would be $221 million those New York hospitals would need to contribute to equally contribute to the network-wide days cash on hand. Does that sound roughly correct?
Yeah, I'm not quite following the math, but I think when we show you we can give you the exact number of the cash for each partner, the cash in the short term and the investments that are sitting at each partner and the network, and give you the average daily expense for each partner so you can see exactly how we get to 131 days cash on hand.
Okay. And that'd be great. And just directionally speaking, are the New York hospitals contributing at least 130 days cash on hand for their portion of the network-wide days cash on hand?
Again, I'll have to take a look. I know that Elizabethtown has, I think, close to over 200 days cash on hand. The other two partners have less. So when the fact that you're looking at it as three combined organizations, I'd rather just do the exact math just to get you the number that you're looking for.
Okay. I'm not suggesting anything with this question. It's merely a question. But if the network were to drop the New York hospitals, would your days cash on hand needs decrease?
So we anticipated this question, and it's a very theoretical question because the impact that the New York hospitals have on our overall network is incredibly positive from a patient flow perspective, even a financial perspective, as Dr. Leffler was describing earlier. Being able to keep those patients local impacts the amount of access and capacity that we can have at the UVM Medical Center. So it's a little bit of a theoretical question. I'll just leave it at that for right now.
Understood. It's a theoretical question. Let me probe that. Essentially, the testimony earlier was that, hey, this is positive for Vermont because of the financial impact that we'd have if all these patients were here rather than over there. And also, it's better clinically to be able to have them here and there. But doesn't that answer suggest that those hospitals wouldn't exist but for Vermont's financial support?
Again, a bit of a theoretical question there. I will just say, just specific to the UVM Medical Center, we in the numbers that were quoted in my opening remarks, just so that the board and the staff know where those numbers came from. It comes from the New York and Vermont funds flow document that we've been providing for many years. I think we started providing it in 2017, and the data goes back to 2015. One of the numbers on there is actually the margin that's generated by the UVM Medical Center through patients coming from New York. When you take a look at just that number and compare that to the funds flows, if you will, trying to take a theoretical question and bringing it down to, somewhat of a analytical question or analytical answer, if you will. When you take a look at the margin that's been generated at the UVM Medical Center by those patients, which those patients certainly, if they were not part of the UVM Health Network, those patients could be going to Rochester, they could be going to Albany. It's not a guarantee that those patients would be coming here to the University of Vermont Medical Center. But when you look at that margin that's generated compared to the investments that have been made over that same time period, the days cash on hand impact is fairly minimal. So when you look at the margin compared to the investments, I think the calculation I did was about a 4-day cash on hand difference. If that margin were no longer, the margin was gone, and if the investments that were made in the New York partners were eliminated.
Has your flow of patients from those New York hospitals increased with your contributions to the New York hospitals' finances?
I think even on that document, Chair Foster, it looks like it's been pretty much steady. There hasn't been an increase, and if anything, as Sunny and others have stated, we're trying to actually keep more New York patients local. Better for them, better for the communities. I don't know, Steve, if you have any more anecdotal information, but just looking at that report, I think you see a pretty flat number coming from New York.
Yeah,
right. Sorry, Dr. Leffler. I actually just want to stay on this line of questions for a second. If it's flat, I guess I don't understand why. So UVM is contributing some financial support, funds flow, I think as you called it, to the New York hospitals. It's tens of millions of dollars. And you're saying, well, we get margin back. But if we don't have any increased margin per your calculations as we contribute more funds flow to New York, what's the benefit?
Again, this gets into a little bit of a theoretical question where those patients, could not be, there's a case to be made that those patients would not be coming to the UVM Medical Center if it were not for this system being in place. I think that's the point that I'm making there. That margin would not exist, would not necessarily exist if this system did not include those New York partners.
What analysis have you done of how many patients wouldn't be coming to UVM if that financial support hadn't been provided?
Again, theoretical question, but we know from early on in the development of our network that we had a very close relationship with Canton Potsdam. The referral base coming from that region was very well established. They actually decided to affiliate with Rochester Regional Memorial, which significantly changed our referral to UVM Medical Center from that area. Since the network's been formed, Glens Falls Hospital, which is on the edge of our market area, has affiliated with Albany Medical Center. And so, again, it's a theoretical question on would CBPH and Alice Hyde have affiliated with Albany Med instead of the UVM Health Network if that relationship didn't exist. And if it did, then that margin would go away.
It sounds like a theoretical answer. You're suggesting that hypothetically, if you hadn't provided financial support to the New York hospitals, these patients would go elsewhere, but that's hypothetical, right?
Can I add to it, but I don't want to interrupt you if you want to keep going, Chair Foster.
Yeah, maybe Mr. Vince, if you can answer that, and then we'll turn to you, Dr. Loeffler.
Yeah, my point is it's not a guarantee that those patients will be coming to the UVM Medical Center. Is I think what I'll just end on.
It's not a guarantee that they wouldn't either.
I think there's a couple. Yeah, I think there's a couple possibilities, and I agree. All of this is hypothetical, theoretical, whatever. One possibility is that those hospitals would affiliate with Rochester or Albany, and that would potentially have a huge impact on our specialty services. Cancer care, heart surgery, thoracic surgery, high-end neurosurgery, NICU could all be affected by that loss of those patients coming here. That would be devastating to our academic mission. The other option is that they would not be looked at as a good site for affiliation and they'd be totally on their own. In that scenario, they probably lose even more services without support, and we're overwhelmed with patients who don't need tertiary care but are coming to Burlington for access to care. Either one of those options for totally different reasons is a giant problem for the academic medical center. Either too many patients that we can't serve because we don't have beds for them, or not enough specialty care. Having those be part of the network, stabilizing the appropriate referrals here, keeps our specialty services strong for Vermonters and keeps the right patients in New York. So we're in this balance. I haven't seen the exact dollars to show that is the right balance, but academic medical centers across the country do it for exactly this reason. So that's what I wanted to add, and I appreciate the opportunity to do that.
Thank you. So when the medical center has financial concerns here, you come to the board and you ask for more commercial revenue, and we may or may not give it to you depending on the year. Why don't you do that with the New York hospitals? Why not be financially solvent and sufficient with New York payments?
So I'll just say that the commercial rate increases that we've presented to the board, hopefully we've had a really transparent track record where it's not been based on financial difficulty. It's been based on the cost inflation that we're expecting for the coming year, taking out the government payment rates that we're expecting, and that's been the calculation that we've been doing for commercial rates for as long as I've been in this role. And even if you look at the presentation from today, the breakdown of the commercial rate and what was required wasn't based on the need for achieving, because of financial difficulty or
well, the cost inflation can lead to financial difficulty. I mean, I'm just generally, you ask for more money because you say you need it. And so my question is, your New York hospitals need more money. Why don't you get it from New York?
So in terms of commercial rates and the negotiations in New York, actually, those have been increasing, and Kaylee Champney can provide. I may be getting into some an area.
But
where
here's
we-
my point. They can't be sufficient because the days cash on hand at your biggest hospital is exceedingly low, and at your second biggest hospital is exceedingly low. And there's a funds flow of tens of millions of dollars from our Vermont Academic Medical Center to the New York hospitals. So what you're getting in New York is not sufficient. Is that fair?
Yes, it is fair.
Okay, so why are you not getting enough money for those hospitals from New York?
So that's where I was going with my point. So when we're looking at the commercial, and again, I don't know if this is executive session or not, but the commercial negotiations in New York have looked very, very different than they have in Vermont the last few years. The increases that we're seeking are much larger. They're going to be much larger again this year. We do the same thing in terms of advocating at the state for additional funding. So the same things that we're doing in Vermont, we're doing in New York.
Okay, and the $103.5 million in the due from to UVM Medical Center. Can you give us a breakdown and follow up on what that, who all owes that money? I think I can roughly figure it out, but that'd be appreciated. And then I believe last year you testified there's no interest accruing on any of that money for the UVM Medical Center.
Correct. Those are not considered loans. We're a consolidated entry. We're an obligated group, so there's no interest that we're one organization.
I'd rather see it go the other way, where your New York hospitals are lending Vermont money with no interest. I know it's not, or funds flowing, whatever you want to call it. It just doesn't seem right that you're lending money from this hospital's reserves to another hospital, not lending, whatever you want to call it, financially supporting them, funds flowing. It just doesn't seem right to me to not have any interest on that, because that money, am I correct, that came out of UVMMC reserves?
Again, we'll have to get you the breakdown of exactly where that came from.
Okay, I'll finish up here. Your budget for fiscal year 26 has a $72 million margin for UVMMC. And my question is, sorry, 72 for UVM and 82 million for the Vermont, for the Vermont Health Network hospitals. And this money, to the way I look at it, could be used to support UVM and contribute to the balance sheet and financial stability for UVM, which is very important. It could be not approved. It could help lower Vermonters' healthcare costs. It could be not approved and support FQHCs that are struggling to stay open. It could be not approved and increase Blue Cross Blue Shield reserves and protect solvency. It could be not approved and it could support other community providers. Why should I vote to provide this money to UVM as opposed to any of those other competing interests?
So are you suggesting that you would just take the money from UVM Health System and then distribute it to all the other places?
Well, there's a number of mechanisms that would have to happen for that to occur, but we could not approve it for UVM and then the insurers wouldn't pay it out. And then it could go to their solvency. It could go and flow through to their members who are struggling with healthcare affordability. It could go to lower rates that then are used by the insurance companies to support FQHCs or community providers. Yet the money you're asking for in that amount is money that is not available elsewhere. My question is, why should I vote to approve it for UVM and not those competing interests?
So the reason that we ask for a margin is because it goes in to support the expenses that we have both on the deferred maintenance and capital for our system, right? So if we've already been putting off those deferred maintenance projects. And so not having that money just means it kicks that can down the road even further.
No, I appreciate that. Let me just interrupt. That's the exact same situation for so many others.
Absolutely.
So
absolutely.
So I totally appreciate that and respect it. But my question is, why should I approve it for UVM instead of those competing interests?
Because we provide an incredible service to the entire region here. And so continuing to diminish that ability for us to do that means that the services will not be able to be provided at that same level. That's the challenge. On the New York side, I think I'm just going to summarize what I heard from everyone to make sure that we're on the same page. You might not agree, but if we were not part of that network, if we stopped being a part of the network, as you suggested hypothetically, I think what would happen is that those patients that we currently refer here would go to all those other places because those places are competing for those same patients right now today. Cardiac surgery, neurosurgery, orthopedic surgery. On some of them, we get those patients and we get them to come here and we see the margin value and the provider tax value for that. We also see the value that it provides for us to be able to simply provide those services, whether that's pediatric subspecialty care, NICU care, cardiac surgery, neurosurgery, cardiac catheterization. The only one in Vermont that does those today. On top of that, if we weren't part of that network, what we would see, because patients don't follow borders, and if we weren't supporting the New York hospitals in the way that we are, the other patients would also come to Vermont. They would come to Burlington largely. Those are patients that now that we are working hard to provide the care there, if we stop doing that with the support, all those patients would come. Those are largely New York Medicaid patients that we would have to provide service legally. The borders are irrelevant in the provision of services. We would lose money on those patients. The margin would be negative, and they would crowd out other patients that really need to come into UVMMC. That's the challenge, and that's the rationale for why we try to manage those. The next part, I just want to make sure that you see it, that from FY23 to today, we've made enormous advances for those hospitals to maintain their operating margin. That is to break even or be slightly positive. That's the work that we've invested over the last few years to be able to do that, which only makes Vermont stronger in our hospitals. All of that work is to tie into affordability here in Vermont. The work that we're doing across the system is focused on how do we make care more affordable right here for every one of our hospitals. And so we started with that quality of care and affordability. All of this work ties to that right here in Burlington, as well as all of Vermont. So that's the reason you want to continue to sustain that. If that breaks down, it would be devastating to Vermont. It would be devastating to the region and to Vermont.
Chair
Okay,
Foster,
thank you.
If I can add to Dr. Eben's answer, you asked a great question, and I totally respect the challenge the Green Mountain Care Board faces with deciding where dollars are going to go in Vermont to keep care as affordable as possible. And you outlined a bunch of places that all truly need the money. What I want to say is, I'll speak for the UVM Medical Center because that's the budget I was most involved in. The budget that we built this year met the guidelines the Green Mountain Care Board sent out and did the hard work to make sure that within those guidelines we could have a margin, because we need a margin to be able to support our people, fair and competitive wages for recruiting and retention. It has a margin so that we can keep our equipment current, new defibrillators, new equipment at the hospital, most current updated equipment to take good care of the patients that we serve, and to build something like the outpatient surgery center that allows us to provide care cheaper and more efficiently and affordably going forward. The margin that we submitted, I understand it's a big number. I understand the size of the impact when your budget's $2 billion, but that is the margin. So the margin that we submitted is the margin we believe we need. If the Green Mountain Care Board, in your regulatory power, realigns those dollars to somewhere else, we'll figure out what we can do with the budget that you give us. But that was the budget that met guidance and was what we believe we need to move forward on many big projects. So I appreciate the really difficult decisions that the Green Mountain Care Board has to make dealing with affordability for Vermonters and the other regulated entities that you have regulatory authority over. And thank you for giving me the opportunity to answer.
Thank you. And thank you for your responses and for your budget. I know you all worked very, very hard on this, and this is part of the process is we need to make these hard decisions. And oh, sorry, Ms. Peakley. I want to move on to somebody else because I've taken a lot of the time.
Certainly. Thank you. I did just want to add that something I said early on is when you're talking about numbers that are billion or million, it really sounds like surely you can just shave off some. I do want to say that there are a couple of things that I worry about in FY26 without an appropriate margin, and that margin is coming in at 3%. So not a 10% margin. It's really right around 3%. It is a big number, 72 million. I also wanted to say that a couple of things with that. That margin, if reduced, doesn't necessarily mean that patients won't continue to come and that Blue Cross or other insurers or Medicare won't continue to incur costs for care delivered. So we're not looking to restrict care as a result. I also want to mention that not all of that margin comes from our commercial. Remember, we do have other revenue in there that is quite significant that would be diverted if we're talking about giving that money elsewhere. And we need to make sure that revenues that we're generating, we also are able to cover the expenses that are related to that when it's not directly coming through one of our commercial payers. So I just wanted to make sure that you understood that we wouldn't be necessarily able to close off inflow of patients because we are here to treat them, and that we do have, I would say, one of the most complex budgets in terms of the different types of revenue that come in to make up that margin, and do appreciate the complexity that the board has and looking at the affordability, and we want to partner with you on that and understand it is a very difficult decision.
Understood. One last one. The 103 million due from, is that reflected in UVMMC's days cash on hand?
I don't believe so, Chair Foster, but we'll validate that calculation.
Okay. All right. Thank you all very, very much. I'll turn to Member Holmes.
Hi. I know it's getting late, so I just have two areas of inquiry, but I think they'll be short. One that hasn't come up at all, but the UVM Health Network is the sole parent of One Care Vermont. That hasn't come up at all, but the reason I ask is that I'm curious what the value of the reserves are at the end of this year, and what is the planned distribution of those as One Care Vermont sunsets.
So we can follow up with specifics there, Member Holmes. I don't want to quote. I have a number in my head. I think it's somewhere in less than $10 million. I think at the end of the day, after all bills will have been paid, so we can get you a projection from One Care on exactly where they think that will land. And the run out is actually continuing all the way through June of next year. So even though the program's closed down this December, there's still some cost, granted much less cost that will be incurred from January through June of next year to run down the programs.
And I think also just it would be helpful to understand the distribution of those reserves to the member hospitals, or what's going to happen to those reserves would be helpful to understand. There's also, are the FTEs associated with One Care Vermont currently in the FTE count that we've been seeing at the health network? Or is it separate?
I'm not positive about that. I think they may be. And so we'll get back to you on that as well.
Okay, and then it would also be helpful to understand, will they be retained, or what's happening to that FTE count when that organization sunsets? Okay, and my last question really is, it relates to quality, and I thank you for the transparency and sharing some of the star ratings. It's a concern of mine. And, as we look from fiscal year 22 to fiscal year 26, we're seeing this centralization, we're seeing this consolidation of shared services related to improving quality and improving population health. You have a department, value-based care department, you have a quality department, you have a PHSO, you have the ACO as well. in there. I'm not sure whether they're all fully embedded in the PHSO or not, but as we look from 22 to 26, it increased in the expenses associated with those collective departments. Aside, I'm ignoring the ACO now. $21 million in 22, $41 million budgeted for 26. Staffing went from 139 to 237. So that's a lot of resources devoted to improving quality and population health outcomes. And I looked at, the star ratings. You mentioned where the Vermont hospitals are, but Alice Hyde is 1 star, CVPH is 2 stars, CVMC we know is 2 stars, Porter and UVMC are 3 stars. So we no longer have any 4 or 5-star hospitals in the network. That means and half of your hospitals are in the bottom third of all hospitals in the country, and none are in the top third. So, and when I look back to 2022, UVM was a 5 back then, CVMC was a 5 back then. So I just want to articulate that I'm concerned that sometimes centralization and consolidation of those types of services may move people away from where, at the point of service where quality can really be improved. And I want to ask you, how are you assessing whether or not this is an optimal approach, this centralization, this consolidation of all this quality? And how are you assessing that the growth in staffing and expenses related to quality are providing a positive ROI?
Maybe I'll start. I'll say that the consolidation of the quality services really hadn't started till probably last year. And so the network-wide quality as a network shared service really hasn't happened yet. It's really, the process has just started over the last fiscal year. That's number one. I think you're right. I think one of the concerns that you raise is actually what our hospital presidents have raised, is that as we've squeezed on our expenses across our system, we probably squeezed too hard in that quality space, because quality is a little bit removed. You think about the people that are doing that work are not direct clinical facing. They're the people in the back. You're absolutely right. And so I think really led by Steve and Ramsey here, have really pushed back on the commitment that we need to make both in the FTEs and the people that have to be in that quality space. So we've done that, and we've really reorganized and realigned that space to drive the work there, hired very specific people in order to do that. So I think you're right in everything that you said there, but that we haven't really dedicated the resources and the people to do that. The contrary, I think we've squeezed from the outside and said you've got to reduce people, and that hasn't worked well. The other part of that is, of course, all the things that you've already heard, is that I think we expanded dramatically during the COVID time period. We had lots of travelers in there, and quality did decrease in that space. And then we came back, we had to get back and right size that, just back to the basics. But we've got a plan. It's driven by those CMS 5-star ratings of what do we need to do to target. We're utilizing the power of being able to centralize the data analytics and management to drive that back locally, to say, here's what you need to do in your hospital, in your health service area specifically. So we're trying to leverage the sort of benefit and economies of scale that Drew just had. I think we strayed away from that, and I hear you, and we acknowledge and recognize that. I think all of our presidents have sort of started with that to say we know we've got to do work there. But you're right, it comes down to doing local work, but there's also value in the way that we can do the scale centrally to be able to drive that. So that's what we're trying to do. Invite Ramsey and Steve if there's anything else that you want to put into that space.
Yeah, so I agree with you. You have to have enough people on the ground. So we got the medical center to 5 stars before. I hate that we're not 5 stars right now. It really bothers me. We made a bunch of decisions through the pandemic that took our eye off it. And what I do know about being 5 stars is, to be a 5-star institution, you have to think about it every day at every encounter. Every person here has to be focused on doing it right, doing it well every time. And in the pandemic, we lost that focus because we were focused on other things. As we started to do the work to build back, it does feel at times like the local hospitals don't have exactly enough people on the ground. And now we've started the hard work of making sure to advocate for what we need. I do think there's ways to use the power of the network to make sure we're all working on the same things, that we can have good best practices shared everywhere. but we have to have enough people at the medical center and enough people at CVMC and enough people at Porter to actually do the hard work. I just read a thing this morning before we started this that one of our floors decreased falls multiple by doing 1,000 leadership sweeps over the past 6 months. 1,000 times, hour by hour, the leaders are walking around to make sure that things are happening. That's how you get 5 stars. At the medical center, we do have a measure from Vizient academic data showing that we've started that climb, but that's just a small down payment to getting back to 5 stars. We have to sustain that and make it better. I am confident that the network has heard what we're asking for and that we will do better, but we're not where we need to be.
Okay. I appreciate that. I appreciate the efforts, and I hope when we're chatting next year, it's a different set of data that we're able to look at.
Let me
sorry.
add one last thing. We already know that all of the data for 26 for stars is already in. So really the work we're doing now will start to show in 27. That's the really hard part about CMS star ratings. It's got such a huge lag.
I recognize that. My last question is just about removing wastes across the network. And I think we've talked a little about this when we were talking about the Mayday meetings and things like that, reducing waste and duplication of tests and diagnostics when patients are transferred up to UVM. What do you accept MRIs from and other types of diagnostic imaging that's been done at another hospital, or do you repeat the tests? What are we doing about that?
I would say it depends, quite frankly. If we can, we try to use it. As you know, oftentimes when those patients come in, if they come in from an outside facility, we have to make sure that we actually have it. It's not enough to see the reading. We want to see the image. And then the question is the image good enough? So an MRI is not an MRI. A head CT is not a head CT. The protocols that get driven at different institutions are different. They're for us, they're all read by specialty readers. It makes a difference. So if you're a neurosurgeon and you want to do neurosurgery and you're getting an outside head CT, it may or may not be good enough for them to do it. We try to utilize what we have, but then it's not always the same though. That's the problem that we have. Certainly within the system now, both for labs and for radiology, we are totally centralized. So whether you get a blood test or a lab at Porter or at CVPH or at UVM-MC, it's the same standard, same testing equipment, same protocol. So we can utilize that. Sometimes when they come from outside the system, we struggle for those reasons.
Is there any opportunity to improve that from outside the system? Sounds like you've made some internal improvements. Is there opportunities to work with other hospitals to reduce that duplicate imaging and reduce that cost?
Ramsey, do you want to talk about radiology a little bit?
Yeah, I guess let me go back, Member Holmes, to the first question, because the repeating CTs and MRIs is like, that's right where it hits me in my clinical work all the time. And I will say that the need for repeating images or getting a secondary read has not been uniform, and we've kind of adopted to what's happening out there clinically. So to get some specific examples, right? So if I have a patient that has a multi-trauma that's seen in an outside hospital, and they transfer that patient in, and the images for us are really clear, and we can interpret those images, and we agree with the radiologist that's read those images the outside, we don't repeat those images at all. Sometimes we repeat just some of them. For example, if a patient gets sent to us and they have a CT scanner that doesn't have the definition that I need to look at the cervical spine specifically, we may repeat just the cervical spine CT and not the rest of it. But the most common scenario is that our radiologists are, as Sunny said, there's subspecial radiologists, but just in general, it's not always just the image, it's the interpretation. And so if I have an outside interpretation of an image, we oftentimes don't repeat the image, but we may ask our radiologist to do what we call a secondary read. So we have our radiologist look at the images that are coming to us from the outside, because if it's going to change management, we really need to get the most confidence we can in the read itself.
Okay, thank you. I appreciate that. We're short on time, so I'm going to pass it back to you, Chair Foster.
Thank you. Member Walsh, and we have enough time. I mean, we should finish this up. It's important stuff. So I appreciate UVM allowing us to take a little extra time tonight. Go ahead, Member Walsh.
Thank you. Yeah, and I can be quick. There've been a lot of great questions. So just a couple. We got several key exhibits from the network Friday and even late into the evening. And I was trying to look at those compared to earlier exhibits from the network and compared to years prior. Same data, same output, but it looks different. They're formatted different. So I started to wonder, are the tables that you send to us exported directly from your internal systems, or are they reformatted to be sent to us?
I think it depends, Member Walsh, so that some of those charts that you see there are the specific charts that your staff have asked us to fill out, so they provide the format. Some may be things that we've generated for the purpose of the narrative or the presentation. So it would depend on which one specifically you're taking a look at, whether or not it was the staff or it was us that generated that chart.
If our staff were to ask, would you be able to submit to us the same data format that you use internally, please?
Yes, we can submit data in any format that you would like to see it in.
Great. The networks in the past underestimated utilization. We were talking about this earlier with the medical center, and that's led to NPR overages and mid-year adjustment requests. Have there been any changes you've made to your modeling to prevent those large variances?
Do you want to start,
Member
Judy?
Walsh?
I'm happy.
Yeah,
Go ahead.
certainly. Member Walsh, is there additional information you're seeking beyond what I provided? Are you looking, I was able to speak for my entity. Are you looking for that same information on other Vermont entities within the system? Or is there additional things you'd like for me to elaborate on?
I was just wondering if at the network level, there'd been any efforts made to reduce the variance from budgeted to actuals. The variances, as Matt jumped in after the variances, particularly at the network level, have been substantial.
Yeah, I can speak to that. Yeah, again, on a percentage basis, as Judy, I think, pointed out for the UVM Medical Center, they've been within 5% the last several years, but it's a big, I hear you, Member Walsh, it's a big number because the net patient revenue number for the medical center is so large. We have, I would say, significantly improved the collaboration with our clinical team. So part of building our revenue budget actually is built from the ground up. So we connect with our radiology department, our lab department, the medical group, the peri-op team, the nursing leaders, and they all supply the first pass of the data that is the first building block of our overall revenue. And I would say we've improved significantly there in terms of looking ahead, trying to predict where certain trends are headed. That collaboration has certainly improved over the time that I've been here. The last piece that I think, with global budgets and with some of the other revenue caps and those types of things that we need to look at as a network is actually having some actuarial support. That's something that we haven't done. I think that's the next kind of frontier, if you will, in the building of our budgets, is to look at a little bit more in depth in terms of what's happening with populations, age, demographics, that sort of thing that still is not part of our budget building process.
So the collaboration with the members have improved and you're feeling more confident about the projections, but there hasn't been any external consulting or any modeling, new modeling, it sounds like.
Nothing external, no.
How confident would you say you are in this year's projections?
I think the challenge.
Go ahead,
Member
Dr.
Walsh.
Dr. Epen. Apologies.
Yeah.
Thank you.
Yeah, I think the challenge, Member Walsh, is that I think when I've looked back, I think the challenge has been the demand for our services, for people choosing to come to our hospitals has exceeded what we've expected. And that's a very difficult, when I talk to the clinicians, when I talk to the emergency, it's a very difficult thing to deal with in the moment. And so you project what you think is reasonable based on past years, post-COVID, and then the demand is exceeded. And I think what we've largely done, from what I see, is that when those happen, we go above and beyond in order to satisfy that demand. And we haven't looked back towards where the patients are coming from to say, gosh, you should really stay at Gifford, or you should really stay at, you name the place. We've just opened that up. And if that's meant, opening up our services later in the day, hiring people to work on the weekends, we've done it. And quite frankly, without regard to whether that was going to generate a margin or not, without regard to what the revenue implications were, because I think the feeling was, I guess in retrospect, incorrectly, that that's what we should do, is just open it up. And I think as we've come together, what we've heard, as you've heard from Rick, to be more explicit, is that we need to really be very deliberate about how we do that and look for the alternatives than just opening up that service and doing more, particularly because we know the services that should be done elsewhere, if we do them, it is more expensive, and we acknowledge that. And so I think we've got to be smarter about that. And I've been saying this, but I talk to every single one of the presidents, and I know Steve does, across our entire state. And we are on, everyone's speed dial. We've got it. They call, we say, what can we do to help? What can we do to keep that patient there if we can help? And so I think that's been a shift that I hope we'll be able to see the results of in this coming year, so that our estimates will be accurate. I think there remain a lot of unknowns, which I worry about. And the unknowns, of course, are what's going to happen with our Medicaid patient population, what's going to happen as a result of whether or not folks who are on the fringes of being able to buy their insurance on the exchange, are they going to do that or not? And how that's going to extrapolate out. I think there's a lot of unknowns there, but I think, I don't know if that helps or not, but I think we're a little bit more together on that today than we were in the past, meaning that any given hospital today can't just open up that door, open up that Saturday service, open up without us coming together and really talking that through and thinking about, is that the right thing to do for the community, for the state, for that patient overall in the long run? So I think that is different. I've seen that difference even now in my third year than compared to when we started. So I think we're going to see the results of that. Can I say it? I can't say it's going to be great. That's all we can do is try. Go ahead, Steve. I'm sorry.
Sorry to interrupt you, Dr. Epen. So what I would add is I've been coming to these hearings since 2011. And for most all the years I've come to the hearings, in general, the net patient revenue, if you could explain that your revenue was increasing because of increased utilization with new unique patients, that was usually allowed every year until last year. And then last year, the Green Mountain Care Board said to the network and the medical center, look, we're going to do this a little different now. We're going to hold you to that exact number. And so we've started to do that work of understanding that's a hard number now, and you really can't exceed it. And we have started to shift. We are dealing with our enforcement from 23. We have an enforcement that's in our 26 budget and will be in our 27 budget. We're working hard now to keep patients closer to home in New York when it's appropriate, in the hospitals across Vermont. and much more thoughtful about how the revenue comes in. But it was a change last year in our budget guidance, and we are working as quickly as we can to make sure that we keep the revenue down. This year, for the first time that I can remember, our net patient revenue is under guidance because we're going to try hard to keep people at their local institutions when it's safe for them, when it's good care, when it makes sense. I do think it's a shift, and we are working as quickly as possible to understand and to be compliant with what you're asking.
Okay, thank you. Also in the information that came on Friday, there were data with projections through 2029. And I made a bar chart of that. Matt, could you pull up that bar chart, please?
Pulling it up right now.
Thank you. From the information that we received on Friday, operating expenses are projected to grow nearly 40% from 2023 to 2029. Does that amount assume ongoing efficiency gains that you'd be working on during that time?
So those assumptions in the financial framework, Member Walsh, those are really more geared towards the margin that that revenue and those expenses generate, in terms of the thought put into the expense projections going out that far. That we have to refine. It doesn't have as much detail and as much thought into it as our annual budgets. This is to generate where does the margin need to be to generate the resources that we need in the years ahead. Looking at the combination of days cash on hand, margin, debt service coverage ratio, and our average age of plant. So that's how we use the data internally. Each year, we're then taking this framework focused more on the margin and those other metrics to then say internally, what do we have to do if the revenue number isn't going to hit what we projected? What do we need to do in terms of expenses to get that number down to hit that margin that we've got in the framework?
I see. So there aren't any built-in efficiency assumptions with this. It's efficiency is not the point here. It's to be able to project the revenue and then looking at, well, what do we have to spend internally in order to be able to generate that revenue? So there aren't assumptions about decrease in operating expenses. So the net patient revenue is projected to increase about 38% over this same period. Given past under projections, is the 3.4 billion in net patient revenue perhaps a low estimate out to 2029?
Yeah, again, our focus going out that far in this model, Member Walsh, is really about the margin. So every year we refine this to what we believe is going to be a closer approximation of both the revenue and the expenses. So the way that we use this internally, I wouldn't view this as the roadmap for where our expenses and our revenues need to be over the next 5 years. It's really a roadmap on where our margin needs to be over the next 5 years to generate an appropriate level of days cash on hand. It tells us in what year do we believe that we might be able to use some of our debt capacity to help fund our capital needs. But the precision in terms of the revenue and the expenses in this that you see here, that's done essentially every year, except for this year, given the changes in both. One of the things that we're modeling that in next year's framework, you'll probably see a little bit more refinement is one, looking over the next several years on getting the commercial percentage of Medicare down to a certain level, back to the affordability issue that we're trying to solve. And also projecting out what we think is going to be happening with Medicare, with Medicaid over the next several years.
Yeah, that's helpful. I think margin's a relative number, right? So you could have very high revenue and very high expenses and a small margin. You could have less revenue and much lower operating expenses and have a larger margin. So just so I make sure that I understand that. That's all. I know we're short on time. Thanks for being here and answering the questions. Back to you, Chair Foster.
Thank you. Member Teachout.
Great, thank you. I'll keep my questions focused. In the documents about the shared services across the network, you also had, I'm just going to look at it here. You also had revenue attributed to the different shared services lines. And so I'll just focus on the three largest, and certainly it wasn't as big. But you had 15.5 million of revenue for the PHSO. You had 5.4 million in revenue for UVM HN administration. And then you had just under $1 million for HN development. Can you tell me the sources of those revenues, starting with the PHSO?
And before I get to that question, just to make sure the board realizes those revenues, when we're talking about allocating shared services, that allocation includes that revenue. So essentially, it decreases the overall expenses that we're allocating to all of our network partners. For the PHSO, that is primarily population health management payments, quality incentives, those types of things. So there's still 3 months left of so pretty much all of the OneCare revenues, non-patient related revenues are in the PHSO. There's been some assumptions made for our Pearl ACO that will start in January. That is another component of the revenue stream there. As I mentioned earlier, the PHSO is starting to offer its services outside of the network. So it's actually providing services to the University of Vermont, which has created a new revenue stream. So that's the bulk of the PHSO. Development, I think that small amount there is related to I think just some merchandise, if you will, that we're planning to sell. So UVM Health Network related merchandise, and then the 5 million in the UVM Health Network administration costs. And I'll have to get back to you on that one. That's not unless somebody else on the call is aware of that. I'm not remembering exactly what that revenue is there.
Thank you. So the PHSO one is actually increasing from FY25 to 26 from, hold on, from 11.7 million to 15.4. So it doesn't seem to indicate like what's happening with OneCare Vermont going away.
Yeah,
So
like I said, we've got a new contract with UVM. I don't know exactly what the amount is there. Remember,
Okay.
Teachout, but that may be offsetting the decreases that we're seeing from OneCare.
Okay. And then when you allocate, you rightly guessed what I'm getting at. When you reallocate these back out to the hospitals, I thought you did it as a percent of their, I think their revenue. So is this getting allocated? The PHSO is helping also on the New York side and they're paying for their portion?
Correct.
Okay. Thank you. And then the other question I have is related to the liaison's recommendation of capping commercial prices at 500%. I think it's just for Blue Cross. Do you support the recommendation or are you supportive of it?
I think we haven't really spent the time really looking at what that would mean and the timeline to get there. And I think that's for the whole state as well. And so I think obviously we would want to make sure that AHS and others have weighed into what that would look like and what that means. So I think it's really early for us, but our goal in general is if that's going to be what we need to do to make affordability more likely to happen here. That's what we want to support. So I think you can be confident that we want to do that and be sustainable, of course, to serve our patients. But I think it's too early for us to tell if that's the right number and also what the timeline is. And I don't know. That recommendation went to did it go to DFR? I don't know where it went, or AHS, but they'd have to look at that, I suppose, actuarially to see if that makes sense for the state.
Thank you. I noticed that you said that you're trying to get your commercial percent of Medicare down. That's a longer term goal, and those two kind of goals coincide. My other question is why, and I know a little bit that this is mixing apples and oranges, but why are you increasing your commercial charge masters when you're trying to get your prices down?
Gonna
I
just
can
keep
chime in.
pushing that back to Kelly.
Can you hear me? I seem to have some Teams problems, but can you hear me?
Yes.
Member Teachout,
Yep,
can you hear me?
Yep, we can hear you, Kelly.
Oh,
Go ahead.
Sorry, I'm having some Teams feedback. First thing, I want to just go back to your question and a little clarification. As I read the letter from the liaison team, it would apply to any plan offered on the exchange. So the impact does need to be analyzed on MVP and then obviously in the future. But right now we have our two plans. So just wanted to clarify that and have to do that analysis. And going back to the charge master conversation, and again, happy if there's follow-up questions, we can certainly discuss either in questions or with you and staff. So affordability and pricing, the charge masters, as you know, is not necessarily what our payers pay. It does relate to our financial assistance policy, which I know we have provided, and I would defer to my CFO colleagues to go there. As I described before, we are increasing our charge masters to, again, make sure we're not hitting any limits with lesser of, with any other components of the contract terms. We're working in detail with our payers to analyze this. So it's one of those, if you don't do pricing and revenue in conjunction, you get unintended consequences. So you could actually be getting reimbursement higher than what is charged, which is appropriate at times if there's outliers, and again, details in the contracts. But we're doing this as a matter to manage what we charge and the reimbursement terms with payers, which vary, and our charge master is the same across our entire payer. So it's not a different charge master per payer. So it's got to take in a couple of iterations of analysis there, and that's why we have that.
Thank you. Those were all my questions.
Dr. Merman.
I think I get to close out the questions today, so thanks for enduring. I feel like 2 years ago we had this mega hearing, and I think I said at the end it felt like a 12-hour ER shift. This was not quite so bad. I think this was more like an 8-hour shift, so this was much appreciated by everybody. I just have a few questions. This actually came up, Rick, you mentioned the New York funds flow documents. I just pulled it up real quick. And I have one question. I don't know if you can give it to me quickly, but it says percent of UVMMC patient revenue flow from New York residents as a line. And I was curious if you know if that's gross revenue or net revenue.
Pretty sure that's net, but we'll get back to you. We'll validate that for sure, Member Merman, Dr. Merman.
Either's fine. So Dave works too. So I was looking at a updated Fitch audited financial from year end, and it said that UVM HN had 150 days cash on hand at approximately $1.3 billion. And I did the quick math earlier. You said 131 days cash on hand at 9.4 million per day. So it's 1.23 billion. So I have a few questions for you on this. Do you use the same methodology to calculate days cash on hand as Fitch does?
It should be the same, but we'll take a look and see. Perhaps their average daily expense is a little bit off. Which time period were you looking at that Fitch report?
There was an updated year end. So it came out in May, but it was from the year end FY24. It's on the Fitch website.
Yeah, and just to be clear, the 131 that I was referencing is at the end of June of this year.
So in that 6 months, days cash on hand went down by 29 days. Can you explain why that's the case?
Yeah, so we're behind our margin targets, and we are waiting for some cash related to one, our employee retention credits. So we recognize that revenue when we submitted those, but we actually haven't gotten the cash for it yet. So that'll help to close some of that drop that you're seeing there. The other thing is UVM Medical Center's margin and the cash is very much back loaded. So the vast majority of the margin for the UVM Medical Center occurs in July, August, and September. Actually, this year I think it's going to be just August and September related to the enhanced Medicaid revenues. So I think it was at 65 million that I think there was a question from one of the members that actually comes in just the last 2 months of the fiscal year. So that adds a significant amount of cash as well. We do expect that the cash will be lower this year than it was at the end of this year, but not. We do expect it to pick up a little bit from this 131 days cash on hand that we have currently.
Okay, so typically you would expect your cash to be higher after that Medicaid adjustment, and basically at the beginning of the financial first quarter of 26.
Correct.
Could you provide a projection of where you think your cash would end up at the October 1st, the beginning of 26? All right.
Yep, we can do that.
Thanks. And then I assume the denominator, like you were talking about, the denominator daily expenses has gone up between now and whenever this was last calculated. Do you re-update that throughout the year, or do you update the denominator at budgetary increments?
No, we update that. I think it's actually, I'll have to, I don't know if anybody in the team is on, but I think it's monthly that we're updating that average daily expense number.
Yes.
Not, yeah, did I say monthly? Hopefully I didn't say daily. Monthly.
Monthly, yes.
Okay. All right, thanks. There was an editorial in the media last fall or winter around the challenging situation with the budget and enforcement that you had, that discussed that the revenue to UVM Medical Center is made up by 66, 2/3 comes from public payers. Do you know if that figure is accurate?
So Judy, I think that's about right. But
It is approximately, but I have not run the calculation, so I wouldn't want to be quoted that that is still the current.
So
makeup.
into the submissions to the board, it's quite different than that. Last year, this year, looking for the 25 actuals, looks like it's about 40% from public payers, and the rest is made up of commercial insurance, self-pay, UVM's self-insured group. I think you're looking at gross revenue, but that's not revenue. Revenue is dollars, not pseudo dollars. So I do wonder if there's an opportunity for a correction. I think that would help sort of lay the record a little bit more straight.
Have to compare what was stated and clarify if something was gross versus net, because you are correct. What comes in doesn't necessarily end up as the proportion of our net patient service revenue, but it certainly comes in with the originating payer. But you're right, in terms of what drops down to cash, can certainly be different about what's actually making up margin.
Thank you. I don't know if you were available the other day when Matt Sutter gave his intro presentation on the hospital budgets. And if anyone was there, I was just curious if you were aware that 95% of the budgeted margin for Vermont hospitals this year is at UVM Medical Center, which provides about 50% of the which about 50% of the revenue generation, 52, I think, in the state. Were you aware that 95% of the margin is currently budgeted at UVM Medical Center?
I was not aware of that percentage. I will say that it is important to recall that UVM Medical Center's margin isn't made up only of direct patient care. It is also made up of the extended care provided throughout the state through our retail and 340B programs, which does make up a significant amount of the margin as well. So
this was
I think
this was operating margin, so the retail programs didn't apply to that. But yes, appreciate that. The other striking fact from that was if you remove the UVM Health Network hospitals from the overall margin budgeted for all hospitals in the state, it's actually a negative margin. I don't think any other hospital is budgeting more than maybe just barely over a 1% margin. So it's a very tough time in Vermont. So I have the last thing I was going to say, I wrote up a little thing because I felt like I should make a comment and not a question. So I'm going to offer it here. But so UVM has a very big role in Vermont. Many people rely on UVM Health Network for their care, for their livelihood, and as we explored in the risk of closing dialysis, for their lives on a daily basis. All of this, while a substantial portion of Vermonters, people who live in Vermont, but hours from UVMC, who get care elsewhere, will never receive care at UVM Health Network, but they are impacted by the UVM Health Network. That impact could be having the option to go to UVM Health Network at a time of need, like the trauma that Dr. Ramsey mentioned, but it all can also be impacted by the high cost of just having it there. Vermonters live far away in Bennington and Brattleboro, never get to UVM Medical Center or UVM Hospital. So many of the Vermonters who do not live in your service area, but they pay for some of the highest health insurance prices in the country because of the high cost of care at UVM Health Network. I know that it's clear, actually very clear today, that you guys, all of you people feel very committed to your hospitals in New York and to delivering care in New York. And I strongly support excellent care in those communities and wouldn't want that care to be eroded. But it's very hard for Vermonters who have some of the lowest median incomes in the United States to subsidize that care. This submission states that if there are events that impact your budget, this was in the risks section, that you would protect your margin so that you can be sustainable for the future. I would ask you to reconsider this. I would ask you to consider the non-UVM Health Network medical infrastructure, which is in far less stable footing. Our community health centers, our insurers, our independent practices. I would ask you to consider Vermont ratepayers and taxpayers, many of them who just never make ends meet, and definitely not with a 3 to 6% margin. A very small proportion of Vermont hospitals, clinics, small businesses, or individuals even come close to the equivalent of having an A bond rating. So please, while you enjoy massive market power, very high commercial prices, and a remarkably strong payer mix compared to the region that we live in, you also hold the responsibility to not take too much advantage of that position, and to not squeeze the others who maybe just inadvertently, but not blindly, get brought out of existence. So thank you for that, listening to that. Thank you for being here today, and that's all the questions I have.
Thank you, Dr. Merman. I'll turn to the healthcare advocate.
Mr. Chair, I don't have any questions or comments for the UVM Health Network, though I do have one for the board. Would you like me to make that now, or do you want to wait till public comment?
You can make it now.
Okay. I very much appreciated the concept about the liaison letter. I very much appreciated the concept that the liaison brought to the table of a cap on individual charges, a cap of percentage of Medicare. And I think I see it as a possible way for there to be an incremental step in the direction. It's going to take us a while to get fully to a reference-based price. And we don't want to shock the system too much in any individual step, and that maybe this could be a first step in that direction. I'll be honest with you, the 500% of Medicare just did not match my sense of urgency and concern for our system and our Vermonters. And so I ask the board if you are considering evaluating whether this is something that should be possibly put in play or possibly supported, that you give yourself some room and ask UVM in its modeling of this to model increments maybe between 400 and 500% of poverty, I'm sorry, of Medicare, in order to be able to understand the dynamics and give yourself some room so that when you're making your decision, you have the numbers that you need. Thank you, Mr. Chair. And also, hey, thank you, UVM Health Network. Things I said at the very beginning of the hearing, or my questions earlier, I really mean it. We can both be critical and feel like we need to do more, and also feel appreciative for hard work that's been done.
Thank you.
Thank you, Mr. Fisher. I'll turn to Mr. Sutter and then public comment after that. But Mr. Sutter, does the staff have any follow-up questions?
Yes, I had a question about transfers into shared services, more specifically about how it interacts with the potential operating expense benchmark. If I could share my screen real quick, I think maybe it's easier to walk it through with a basic PowerPoint. So just using an example, like let's say you have a hypothetical department with $100 in expenses and $10 in other revenue that lives entirely at a hospital. If that becomes a shared service, and let's say for this, we're assuming the hospital has 50% of the network revenue. If that becomes a shared service, they still have the revenue live on their P&L, but then there's an adjustment for the net expenses, so we don't double count. And then the allocation, their share of the allocated net expenses is then added back into their operating expenses. In this situation, the total network-wide consolidated operating expenses would be the same. But at this one hospital, they have the apparent decrease of 45, just using the example numbers here. Do I have that correct? Is that kind of how this would interact or could interact?
That's correct. When that does move from just picking your $90 million figure, Matt, it means that hospital, when that allocation's made, they're going to get less expense back than when they were holding the expense in totality.
Great. Thank you. That's my question.
Okay, thank you. And I'll turn to public comment. The hand isn't raised, but I see Mr. Pratt has been here all day, and I really greatly appreciate that.
Yes, I have.
So Mr. Pratt, if you want
thank you for this. This has been very interesting and educational. So UVM, I'm in Rutland, Vermont, and I've had Federal Blue Cross Blue Shield since 2008, and with all the price increases, I still have it. I found out in January that the price of my Wegovy went from a $50 copay to a $616 a month copay. Now, I've been in the Vermont Health Assistance Program. Hope I got this. I hope all of you realize this letter that you sent out, that it's not going to allow me to get care in a local community, because there's 3 qualifications. The first 2 I meet, the third I don't. I don't have an active care relationship within the University of Vermont Healthcare. So when you were asked about if there's going to be any reduction in services and you said no, what if I don't find a UVM healthcare provider? And let's say, how many UVM healthcare providers do I have to have? Do I have to have all of them that I now have here in Rutland? Or could I just find maybe a dermatologist, which it sounds like is up in Burlington? It's about the only place you can find one in Vermont. So what's that going to cost me to go up there? Currently, co-payments for me would be $10,200 a year, because the Wegovy itself is $7,364 a year. that doesn't count any of the other medications. That is something I just can't handle. So when you have on your slides, I think there are 7, 12, 25, 52, 23, 27, talking about the pharmacy and the retail business, and you don't seem to think that that has any impact. Well, I've been trying since March to find out from UVM, talking to Matt through Flint and other people, to find out exactly how many people got this boilerplate letter, because it doesn't have my name on it, doesn't have a signature at the bottom. But when I called the number at the bottom, they said that this is true. This is going to happen. So my runway ends in October. So October 1st, I've either got to come up with the extra 600 and, well, my whole thing. So it's going to be more than that. Or what? Or I don't get the prescriptions. How long would it take me to get in to see a provider? My wife just happens to have a provider, but she got a letter, but the way you had it in your system, it was Terry Loveco and Brandon, but they had her listed as T. Ray Loveco. So you guys didn't recognize her as being a provider. So unless we called up, which we did, and talked to a woman by the name of Kathy, and I don't know how many people you have answering the phones, but she said, well, okay, then I'll straighten that out and your wife's good till May of 2026. The only thing is, we never got a follow-up letter or anything in response to let us know that she won't be kicked off on October 1st. So of that $70 million you're talking about, Chair Foster, I could recommend that some goes to Rutland, because Rutland's 340B program does not provide any prescription help for individuals. It all goes to their different medical centers or the ambulance services. So UVM's program, which has been a huge help to me and my wife, and I would just like to know how many other people or else got this letter, how it's going to impact them, what the cost is going to be. I don't need to know individuals. I just want sort of the aggregate. What is the big number? How much are you going to be saving by doing that? And how much are you going to be making? Let's say all of us that you thought you're going to have saving joined UVM system. You're not going to save any money or do anything that way, from my opinion. So those are just things I'd like answers to. And I have no idea how many people outside of UVM system is going to be hurt by that. But I know my primary care professional told me that there are quite a few of her people that are also in that program. So that's my statement, comment, questions, and I was hoping somebody could eventually tell me how many people are going to be impacted by that.
Thank you, Mr. Pratt. I think it's a fair question. This relates to something I think Member Teachout had asked. So UVM, I'm going to presume you don't have this information off the top of your head, but if you could send into the board how many people will be impacted by this change, and if there is a financial savings component to this change, to provide that as well.
Just Chair Foster, if I could just, maybe I'll direct my comment to you, and then if we can get Mr. Pratt's information from you, contact information, maybe we can reach out. I'm assuming he's talking about the health assistance program yeah, that's right. So because your provider doesn't provide, your insurance doesn't provide the coverage, I think up until this year in that notification, we had expanded the health assistance program after COVID to go well beyond our service area. And I think this year we're pulling it back. And so that you have to be part of our provider service area. But let's get, if we can get your information, we'll follow up on that. Right now, Chair Foster, I think I have some numbers and I'm happy to get these to you, but we cover around 5,000 patients in that health assistance program. And I think the goal was to keep it at that around 5,000 patients. And so as a result of that and the continuing cutting and cost benefits there, that we've pulled that back. But we'll take that on, and if we can just get that contact information, we'll see if there's anything else he qualifies for.
Well, I appreciate I appreciate that answer. Well, I was told there's about 6,000. And when you multiply that by 10,200, which is just mine, that's 61.4 or $61.2 million right there. That's a lot of money. That's a lot of money. So, and Matthew Flint at the pharmacy, who runs your pharmacy program, it's my understanding, has that information. So does your government liaison, because I've talked to Becca Balint and her people. So, but I give you or authorize, and I've authorized them to pass my information on. So if you want that, I'll be glad to get it to you.
Thank you.
Thanks. Mr. Pratt, if you, I think my email contact is available on the website. If you just send in your information, I'll send out Dr. Epen's info. I'll pass it along. And thank you. And thank you, Dr.
Thank you very much. I appreciate that.
No, good to see you. And thanks for being here today. Mr. Leclerc. Oh, sorry. Actually, I'm out of order. Martha Lang.
Hello, I'm Martha Lang, and I'm here to talk about the University of Vermont's McClure Garage. I own a substantial amount of real estate directly across the street from the McClure Garage. That's my interest in it. My family was involved in the original Act 250 permit for the garage, 1982. I have monitored the behavior of the groundskeepers around the garage constantly. I live across the street from the garage. I'm very concerned that they want to try to tear it down. I asked to do a study, an engineering study. I'd pay for it myself. And UVM denied me that right. And no engineer is going to work for me if I don't have the permission of UVM. So UVM Medical withdrew their certificate of need, saying that after 2 months they would have a engineering study and it would cost them $28,000. I'm asking you people to ask them if they ever did the study, and if they did, what the results were. I'm of the mind that the McClure Garage is not in the condition that UVM Medical Center says it is, and I'd like to prove it, okay? I'm a very good neighbor, by the way. I don't cause any trouble except this. Now, the next thing is I went through as best I could that budget and all the information. And interestingly enough, one of the categories under other revenue was there's $7.7 million revenue from the garage and the cafeteria. Just as I would suspect that most of that revenue is from the garage. That's a very small cafeteria up there. They're probably lucky if they break $1 million. Why can't the money that's being generated from the parking garage go to rehabilitating the McClure Garage? And it's a terrible idea if they're cost cutting, which they want to do, means that they're going to delay necessary maintenance. I own real estate. The last thing you want to do is delay maintenance because it only gets worse. You want to try to contain the issue and work from there. It's been a long day. I appreciate all your hard work, and I am very grateful that I can post my thoughts and comments to the Green Mountain Care Board. Thank you very much. Thank you.
Thank you very much, Ms. Lang. I have to admit, I haven't re-reviewed the CON application recently, but I think it's a fair question about the study. So I guess if UVM, if you have the information available as to whether or not the study Ms. Lang referenced has been done, that might be helpful.
We can get you that information.
Ms. Lang, when we get the information, we'll post it publicly. But thank you for, yeah, of course. Thank you for being here and for your comment. Mr. Leclerc.
Alrighty. I got a birthday to go to, so I'll make it brief. The self-pay percentage in the budget that was submitted is the same as 25. That is not going to happen if people can't afford health insurance. I'm one of those people who's considering it and dropping it. I don't have the extra 15 grand to pay in a premium, and I'm not going to use it. I'm just going from my notes here. the leadership is getting a 4% raise based on my math, and their Medicare star rating is going down. That's unacceptable to me. I'm sure they deserve it. The last thing too, the 500% of Medicare pricing is outrageous. I didn't even know that we had CPT codes that were 500% or more. I run a PT clinic. My contracts are between 130% and 150. And at 150%, it's a lot of money for a lot of people. And I cannot stand that their pricing is 500% of Medicare. That's ridiculous. And I would just say a couple other things because I'm the claims person too.